Assalamu alaikum. Welcome again for another presentation and lecture on the safe laparoscopy. So this lecture is about basic laparoscopy and the placement of ports in a safe way. Ports, the ports are of various types. They can be disposable ports and they can be reusable autoclavable ports, and it's are of different sizes. So depending upon different parts of the ports, one can see that there are different tips. So one is the cannula, the other one is the trocar, and the most important thing is the valve mechanism, so that it can allow things from outside into the abdomen, but it does not allow anything, especially the air or the pneumoperitoneum, the gas, from going outside from the inside. So there is a valve mechanism. So first of all, coming to the tips of the disposable trocars and cannulas, they are of sharp variety. Here in the diagram, one can see that there are spring-loaded internal recoil system, and there can be conical tips. The conical tips have a risk of development of hernia, just because that they are of the conical variety. So they are making a hole straight away from the skin and splitting the muscles into the peritoneum, and there is also a risk of hemorrhage, and there are some ports which are sharp and very narrow, and once they get inside the peritoneum, they can be expanded, and they can extend the size of the port, and then you can introduce the cannula. However, there are different types of, some are pyramidal tape. The pyramidal have the advantage that they do not usually cause incisional hernia. And there is another variety, which is the blunt tip ports. The blunt tips are usually of no use to the blind port placement, and they are mainly designed for the open techniques. Then there is the different properties of the ports, that it should not be really heavy. It should be not too heavy, so that the handling is easy while placing the ports. And also they should not be heavy, because at times there is a thin lean patient, and the abdomen is also not big. So only first third part of the cannula is inside the abdomen, while the rest of the cannula is outside. And the part of the cannula which is outside the abdomen has this valve mechanism, and also the lever. So that part usually is going to be heavier as compared to the rest of the port and the cannula. So in that condition, if it is a heavy outside part, it may tend to fall while you are removing the instrument. It may tend to fall and get dislodged from the port side. So it should not be really heavy. In this regard, the disposable ports, which are made of plastic, are excellent ports. However, they are really expensive. So all the things that have advantages do have disadvantages as well, and the things which have disadvantages, they do have advantages as well. Okay, the cannula is usually for insulation, and it should not be reflecting, because if it is reflecting, it may reflect the light inside the cannula, and this may lead to disruption of depth perception during the procedure. And it should be perfectly insulated, because using monopolar diathermy can be a dangerous thing if it is not insulated. Okay, the outside part or the external part, must allow the suture, uh, allow the suturing of the skin to that external portion. Especially this mechanism is required in Hassan's cannula, where the peritoneum or the skin has to be stitched to the cannula, so that the cannula does not drop off of the abdominal cavity, or it should not go in and out of the abdominal wall. So there should be some place for the suture to get anchored from the skin to the external part. Then there is a removable valve. This is really important, because if the valve mechanism is not removable, then there are certain sutures, like for example Vicryl 1 or Silk 1, which have a bigger needle, so they cannot be introduced into the abdomen through the valve. And also the gauze piece, which we usually use to wipe off all the redness on the field, so as to improve the vision, or as well as to control the small venous bleeds. So that gauze needs to be introduced. So if the valve mechanism is not removable, you cannot place in the gauze or remove the gauze, because that gauze will get stuck. The needle will get stuck in the valve, because it is a one-way valve. So it will get stuck in the valve, and things will not be as smooth. So and there are then different parts, different sizes of the ports available: 3 millimeter ports, 5 millimeter ports, 10 millimeter ports, and 12 millimeter ports, as the need may be. Okay. Then a very important thing about the trocars, as we discussed earlier, that there are different tips of trocars available. They can be sharp, they can be conical shape. All those two, sharp, conical, and even the pyramidal, they can get the injuries within the peritoneal cavity, in the form of gut injury, small bowel, large bowel, liver injury, spleen injury, stomach injury, major vascular injuries. All those can happen. So while placing the trocar, some precautions need to be taken. The first thing that is not mentioned on the slide is that the dangerous site has to be identified. If you are placing a port in the midline, it is bound to hit the major vessels, the inferior vena cava or the aorta. So one has to be away from the midline. If the kidney is enlarged, if the tumor is big, if the liver is long enough dropping down, if the spleen is enlarged, so those can be injured. If the sigmoid gut is distended, for that matter, the patient is constipated, and so in this case, the patient is prone to have a trocar injury, especially the first trocar. So another important thing about the trocar injury is that the skin incision is inadequate. At times, the surgeon becomes greedy to reduce the size of the port site incision. Like for example, if it is a 10 millimeter port, so you have to make an 11 millimeter, 11.5 millimeter, or for that matter a 12 millimeter incision, so that that incision can accommodate the 10 millimeter port. So if for a 10 millimeter port, if you are making a 10 millimeter incision, so that can lead to problem. What kind of problem? The problem is that the trocar will not be fitting into that incision, so you have to apply more and more pressure, so that when it suddenly gives way, the abdominal wall and the skin, it suddenly gives way to the metallic or the plastic trocar of 10 millimeter. This sudden movement or sudden inside movement of this trocar can lead to injury inside the abdominal cavity. This is one thing. And the second thing is that you must understand your insufflator. Like for example, for 5 seconds you have applied a trocar pressure, and the machine senses that there is pressure, so it gives a beep after 5 seconds, and this beep is for 5 seconds more. So within that beep, if you do not release that pressure, what this insufflator is going to do? The insufflator is going to suck the gas back, sensing that the pressure within the abdomen has increased, so it sucks the gas back, so that the gas pressure inside the peritoneal cavity is brought to the preset pressure level. So that also leads to a decrease in the pressure, and decrease in the distance between the skin, for that matter the trocar, and the viscera inside the abdomen, and this can lead to trocar injury. So the incision must always be large enough to accommodate the size of the cannula that you are placing in. So this is one thing. And another thing is that when you are introducing the cannula, it should be rotatory movements, not the movement in just one direction, just pushing it inside the abdomen. It should be rotatory movement. This is one thing. Number two, you must hold the cannula like a pistol, and this finger should be on the stem of the cannula or the trocar, so that if there is inadvertent sudden movement of the trocar inside the abdomen, there is a finger, this index finger will prevent further movement of this trocar into the abdomen cavity, and will be helpful in saving the trocar injury. And another thing is that you can hold the cannula or the trocar with the second hand, just stabilizing it, and then you can push in the trocar, thus preventing the trocar injuries. At times the abdomen is small, however incision you may make larger, however rotatory movements you are doing, and you are applying the finger and everything, even then the abdomen is so small that the trocar may touch the surface of important structures, the vascular structures, or the gut, or the liver, or the spleen. So in that case, you can stabilize, you can hold the abdominal muscle, and you can pull it, so that while placing in the trocar, it does not get pushed as well. So in this way, you can avoid the trocar injury. Then of course the third one is mentioned here, is excessive and uncontrolled force in the axis of the trocar, and this may be due to inadequate muscle relaxation. So you must talk to your anesthetist that the muscles are not properly relaxed. So once there is proper curization, the muscles are relaxed, and then the pneumoperitoneum is created, and ports are placed. Inadequate insufflation, of course, if you are aiming for a 12 millimeter pneumoperitoneum, and the pressure is 8 millimeter, you should wait a bit so that the abdomen gets tense, and then you place the trocar. And then counter traction, of course, with the one hand you hold the abdominal wall, apply a counter traction, and then you place the trocar and push it in. The trocar injuries are not uncommon. 0.4 to 0.5% vascular injuries are reported. 0.5 to 0.8 in cases of bowel injuries have been reported, and the mortality can be as high as 7%. However, these injuries usually occur at the time of placement of the first trocar. So once the first trocar is placed, the rest of the trocars are placed under vision, and these injuries can be prevented. But in the first trocar, you must apply those principles which we already discussed. Or if you are still in doubt, it's better to place the first trocar under vision, which is the open technique. Okay, the risk factors for trocar injuries are obesity. If the abdominal wall is very thick, of course, you have to apply more and more force in order to get into the peritoneal cavity. And application of this force is dangerous. And previous inch surgery, of course, in previous surgery, especially the abdominal surgeries, there are scars and there are adhesions of the small bowel and the large bowel to the anterior abdominal wall, and in such cases they can get a trocar injury. So in that case, open technique needs to be favored. And the type of trocar which you are using is also really very important. As I mentioned, the sharp tip trocars, the conical shape, and the spindle shape. And the technique of placement is really in your control, so that needs to be considered. Okay, then comes the arrangement of the ports. The ports can be ipsilateral, which is called sectoring. uh, it is different than the open surgery. In open surgery, we usually do a triangulation, but this is usually performed in gynecological surgeries and in pelvic surgeries. So the camera is toward one side of the ports, and the two ports, the working ports, are on the similar side. So it needs really specific movements. It is extremely difficult. You have to be really expert in laparoscopy for applying this sectoring method of ports arrangement, and suturing is almost impossible. It is only good for dissection in the pelvis, but suturing cannot be performed. However, many expert surgeons can perform suturing as well. And so the camera is one side, and the cameraman is really more comfortable because he's or she is towards one side, and there is no touching of the body and arms and all those things. And then is the triangulation. It is more like open surgery, and it is very good for the beginners. The hand-eye coordination is really best in triangulation, and it is best for suturing as well. But the problem is that the camera has to be in between the ports, so one arm of the cameraman has to be somewhere between the arms of the surgeon, or in the axilla of the surgeon. So it is really not very comfortable position. Okay, now, so let's come to the techniques of port placement. The first one is the blind technique, which is called the Varys needle technique. The Varys needle is composed of basically two parts. You can see in the figure here that there is an outer part and there is an inner part. The inner part has a sharp tip, and there is a spring mechanism. So the sharp tip is usually, this is the sharp tip, and this is the outer blunt cannula. This is outside the cannula. So when you go in and there is no structure in contact with the tip, so you will go in like this. But whenever there is a structure in contact with the sharp end, with the blunt end, the blunt end will go inside because of the spring mechanism, and the sharp end will be in contact with the tissue. So the sharp end will be cutting through the tissue. Once you get through the tissue, the spring mechanism will bring the blunt outer coat of the Varys needle outside. So this is the mechanism for placement of this Varys needle in the peritoneum for pneumoperitoneum. So and this technique is called the Palmer's technique. You must first flush the needle in order to get any clots or fats and see that the needle is patent, because once you are inside, you will have to perform some maneuvers to make sure that you are inside the peritoneal cavity. And of course, you have placed this needle for creation of pneumoperitoneum, and so you will be creating pneumoperitoneum, and the gas has to go in, and the machine, the insufflator, has to measure pressure inside the peritoneal cavity. So the needle has to be patent. That has to be checked. The spring mechanism needs to be checked before placing. So there are 2 or 3 distinct pops while you are placing the needle inside the peritoneal cavity. So if you have made an incision with the blade in the skin, then there will be 2 pops of the needle, and if you have not made the incision, then there will be 3 pops. So the first pop is for the skin, the second pop is for the muscle sheet, and the third pop is for the peritoneum. Once you are inside the peritoneum, then you have to make sure whether you are in the peritoneum or in some wrong place. Then you have to get the saline in, and then you have to suck it. Some people prefer that first you have to suck and then instill the saline, so that the contents within the cavity that you are in should come. If it's in the blood vessel, blood will come. If it's in the gut, some gut content may come. So suction and then irrigation, and then you do a drop test by making the abdominal wall pull towards you, and then you place and put some saline in the needle. If the after pulling the abdominal wall, if the saline is going inside, then it means that you are in the right space. And once you do all this hanging drop test and things, then you start and connecting the gas to the needle, which will create pneumoperitoneum. So first 200 ml of gas, when it goes, if you are in the right space, the liver dullness on the right side. If you are performing a left-sided procedure, the spleen dullness will be gone. It means that you will be in the right place. And the actual pressure is then sensed by the insufflator. Once some pressure is created, let's say for example 3 or 4 pressure is created, then you pull the interior abdominal wall towards yourself, so the pressure inside the peritoneal cavity will be reduced, and that will be sensed by the insufflator, which will also make sure that you are in the peritoneal cavity, and then you leave it, and then there you look at the symmetry. If there is asymmetrical distension of the abdomen, then it means that you are in you are maybe in the stomach, you may be in the small bowel, especially in the large bowel. But if the abdominal wall distension is symmetric, it means that you are in the right place. So this is the technique. Here you can see that the spring mechanism is checked, and then flushing is done, and then needle patency is checked, and then this is the first click, and then the second click, and the third click, and then we instill the saline inside, and then we suck it. It's not coming back. If it was in some closed cavity, the saline would have been sucked back, so it did not. And then we attach the gas to it, and then the hanging drop test. Then the open techniques indication, I mentioned earlier that the patient is really thin. There are multiple abdominal surgery scars, and the patient is really muscular, if the patient is really obese, and if it's a pediatric patient, and if you are in the early stages of your career, you must go for the open technique. It has decreased major vascular injuries because everything is done under vision. You see the peritoneum, and then you place the cannula, and the vascular injuries are recognized early and are treated early, and it is a really favorable technique for the beginners. And in order to build your team confidence in you, and the anesthetist confidence in you, and to boost your self-confidence, this is the best way to create pneumoperitoneum. And of course, it is illegal to perform pneumoperitoneum by a varus needle in certain countries, like there is a total ban on varus needle in Australia. So this is the technique here. The incision is made, and then small retractors are retracting the subcutaneous tissue. Then you reach the sheath of the and abdominal wall, and that sheath is incised, and then gradually, with retraction, slowly and gradually, the peritoneum is identified. It is grabbed between 2 artery forceps and is then cut, and we have to make sure that yes, we are now inside the peritoneum. And then you take stitches on the 2 sides of the peritoneal layers, and you also tie that to the ports. So this is the technique to place safe ports. As I mentioned, that you must look into the matter of placing the index finger on the shaft of the cannula, and you can also grab the shaft of the cannula so that the sudden movements of the trocar into the peritoneal cavity does not occur. Then when you are placing the second trocar or third trocar after you have placed the visual port inside, then it's really difficult. So what you are going to do is that it has to be perpendicular to the abdominal wall, the trocar. Once the trocar is through the skin and the subcutaneous tissue, and it is through the muscle, then the tip of this trocar is shown and is engaged into the peritoneal cavity. Once it is engaged into the peritoneal cavity, then it will not make an oblique tunnel. So because making oblique tunnel is not good, I will discuss that. So once the tip is engaged, you can direct the trocar and the tip of the trocar to some area which is empty. Let's say, for example, if there is distended stomach, you can direct it away from the distended stomach towards an empty space, and then you push and place it. So that will be because the oblique tunnel is not ideal, because it will break the muscles, it can fracture the muscles, so there can be hematoma, and it can also limit your movements of the working ports. Thank you very much for the kind listening, and I hope you have learned something new. Thank you very much.